in terms of unmet needs, the number one thing is that there are patients who have a BRAF V600E mutation and they don't know it because nobody's tested them. And that's a complete tragedy and so easy to fix. So you should test your patients. It's part of every guideline. It's an FDA-approved approach. If you have a non-small cell lung cancer patient, there is no reason not to be testing them for BRAF V600E mutations. Second unmet need is, wouldn't it be great if this regime was better tolerated? I think that's challenging, so we can just try and manage it as best as we can. And then the third unmet need is we desperately need next-line targeted therapy that has to be informed by the biology of how people develop acquired resistance. And we're always going to look to our melanoma colleagues to figure that out. They have so many more of these patients than we do, but that's a real unmet need. At this year's ASCO, we saw a very small amount of data on using palbociclib, a cell cycle inhibitor, with a response in maybe one patient. And so I think that's a work in progress. But generally speaking, at present, if you're progressing on the dabrafenib, trametinib, your next approach is going to be chemotherapy or immunotherapy or chemoimmunotherapy or some non-BRAF directed trial. We don't yet have a targeted second-line approach. I think unlike the other driver oncogenes, there's some evidence that the BRAF patients tend to arise in smokers. They tend to have a somewhat higher tumor mutation burden, and consequently their response to immunotherapy is the same as that in other lung cancers. So it's running about 23-26%. And so I think you're very free, once you move past the targeted therapy, to consider some kind of immunotherapy approach.